Hello, everyone. All very welcome to Emerging Leaders Symposium Day 2. I'm Mahnaz Bahri-Khomami, an early career researcher from the Collaboration for Enhanced Research Impact, or CERI, based at Monash University. We are thrilled to have you join us to workshop 2 today on co-design with consumers, citizens, and communities. Firstly, we would like to thank the Prevention Center and its funding partners for their support for this symposium. We acknowledge Aboriginal and Torres Strait Islander people as the first Australians and traditional custodians of the lands where we live, learn, and work. Why do we care about co-design? As you know, co-creation and co-design between community members, researchers, practitioners, and policymakers is useful for finding solutions to complex health problems that are accessible and meaningful for the intended end users. Increasing the participation and involvement of end users can strengthen innovation, implementation, and overall success of population health initiatives. Engaging, respecting, and applying these multiple perspectives provides context-specific, practical, and relevant knowledge with flow-on impacts on health equity, citizenship, and social justice. So the aims of the workshop today are to first understand the importance of building and maintaining community connection for underrepresented groups and diverse communities, and second, to improve researchers, practitioners, and policymakers' confidence and competence in engaging with communities at all stages of the project lifecycle. Today, we are having 3 amazing speakers. The first will be giving you a general overview of co-design. The second will present a case study on First Nations Resources Project on polycystic ovary syndrome, or PCOS. And our third speaker, which will be the last one, will present another case study on tobacco control project in Arabic-speaking communities. Before I introduce our first speaker today, I encourage you all strongly to pop your questions into the chat box while our speakers are talking. We will be monitoring chat box and we pass on your questions to the speakers. We will probably have time to answer 1 or 2 questions at the end of each talk, and the remaining will go to our Q&A session at the end. And now, our first speaker today. Our first speaker is Mitchell Bowden. Mitchell is an engagement practitioner with experience in health, public health, social service, research, and government settings. Mitchell has Monash University bachelor's degrees in health sciences and social work, from which he graduated in 2013. Mitchell's main strengths are in facilitation, interpersonal and written communications, and relationship management. He has managed many health promotion and community development projects, working alongside community leaders and members to first identify and prioritize health and well-being needs, and second, to design and deliver projects and programs that leverage community strength and resources to address them. Mitchell has strength in bringing together professional and organizational stakeholders in similar to or aligned engagement activities. Working in this way has seen Mitchell collaborate with community and professional stakeholders alike to develop local government strategic plans, create capacity building resources to improve policy and practice, and even publish a healthy cultural cookbook. Very welcome, Mitchell. Over to you. I'll stop sharing so that you can share your slides. Over to you.
Thank you. I don't know about anyone else, but it's always so cringy when you hear someone else introduce you. Ugh. It's like writing a resume, isn't it? So sorry you all had to hear that. All right. So this is me. You heard a lot about me from Mahnaz, so I'm not going to go on a little bit more about me. I thought I would just start by sort of saying that today, or particularly in this workshop, you're going to hear a lot about the things that we can achieve when we work together, and when we work with the people that matter, essentially, which is, in this case, the people for whom our work aims to benefit. And you'll probably hear a lot of different words used to describe this kind of work. So the current buzzwords, you know, co-design, co-production, co-create, all of those words. Others are probably a little bit more common in different sectors. So I know in research we use consumer and community involvement, or CCI, quite a lot. In some parts of the world, for example, the UK, they use public involvement a lot. But the ones for me that I think have stood the test of time that I use probably more than anything else are community engagement, or stakeholder engagement, or just engagement. And at the heart, I guess what we're doing is working with people to achieve a shared goal, or we're collaborating, which is where in the words such as co-design, co-creation, co-production, co-creation, that's where the co comes from in a lot of those present day buzzwords. And at its heart, engagement is really about connection. That's what we're wired for as human beings. You know, there's introverts in the world. That I actually am one of those people. And we all have different levels of comfortability with that, but we actually are wired for human connection. And I think Mahnaz talked a little bit about that already today. So this is a graphic that I teach a lot about co-design, and we run a short course about that, which I'm happy to provide more information about at any point if people are interested. But we run a short course on this, and we present this graphic, and people often sort of sit with it for a while and really think about it. And I think it says a lot. So let's jump in. I know we've only got a short amount of time together, so let's jump in, and we're going to do a really quick poll. So if you're using a smartphone or a device, you can just scan the QR code on your screen or text that number. If you're on a desktop, please just go to pollev.com/co-design. And I'm going to jump into the first question as people are starting to log in. So the first question is, which of the following is not a different level of engagement? We've got inform, consult, there we go, involve, help, collaborate, and empower. And there's no expectation to get this 100% right. This is just a bit of a temperature gauge on how we all see this sort of thing. All right. Very interesting. Okay, we might unpack this a little bit more after, but those who have clicked D, that tends to be what we're sort of talking about here. Engagement is really about unlocking people's resources and the skills that exist within a group of people, as opposed to some of that more savior mentality of we're here to help you, or we're going to do the helping. We as experts with with our experience. It's about recognizing people are experts in their own lives or experts in their own communities, and really it's about not seeing ourselves as someone who could help them, but them actually being able to help themselves. All right, the next one, patient-centered care and co-design are the same thing. Interesting. Great job, everyone. That's a full 100% on the right answer. Exactly. So co-design, they're similar in principle, but co-design is really where we're looking, as opposed to patient-centered care, which is where you might be working one-on-one with an individual patient about putting them at the center of their care, and then you are in fact co-designing their journey with you, or their care plan, or their treatment plan. Co-design is more at that group or community or population level. So you're looking at how do we co-design your treatment plan or your care plan, we're looking at how do we co-design this service or this program from the start, so that it's more built for purpose. All right, collaboration and working with others always makes a project or intervention better. Super interesting. This one I usually get about 50-50 on. Very interesting. My perspective on this, as I said, no right or wrong answer, but my perspective on this is that that's false. I don't actually think. I think we often say that we would like to co-design, and yes, it's best practice, but sometimes it's actually okay to run your own race. And a lot of the times that I think about when I think about that is that if you can't do co-design or community engagement meaningfully or safely to create a safe space for people to participate and feel comfortable and that it's equitable opportunity for that, and you can't do that meaningfully, I actually think it's better to not. You don't want people to lose their motivation to support these things by participating in something that wasn't good, they didn't feel they contributed to, that they didn't enjoy, that they weren't sore about. So it's actually better to just to not. And and I think part of that is an advocacy piece around, convincing people who make those decisions about time frame or the money available or those sorts of things for your efforts. If they really want true co-design and they want you to do it properly or they want you to engage properly, then they need to allocate those things. And if not, well, we're not gonna do that. So for me, it doesn't always make it better. Sometimes it can actually slow you down and make things way more challenging than they need to be. It all depends on the project, really. Okay, really quickly. So which of the following are tools that you can use to help make engagement efforts meaningful? All over the shop. Yeah. All right. Well, I think the people that have clicked on D, that's probably where I would have gone. So we don't tend to use contracts. Communications plans and marketing with authors, maybe they're useful to help make engagement efforts improve your reach, but in terms of making the engagement efforts more meaningful, maybe not so much, possibly, but not so much. And stakeholder matrices and phone numbers again, maybe more for the implementation stuff, but really around your making sure the engagement and the efforts you put into the relational side of the work. We often use MOUs or terms of references or group agreements, and we'll try to unpack a little bit of that after. All right, lucky last. So when recruiting participants for your engagement efforts, it's important to consider any what that may impact their ability to. Bingo. Okay. All right. Well, we're going to move on just to make sure we leave enough time, but hopefully that starts to give you a flavor of some of the things that we think about when we are planning and making decisions around who and how and what we do to engage. So I guess really quickly, what underpins engagement are some of these principles. So for me, it is collaborative. That's where the co comes from in a lot of those words. Where possible, it's really about privileging lived experience voices. So it recognizes that there is privilege all over the shop elsewhere, and us as researchers or us as project managers, we come with a set of privilege and a set of power. And so this is around shifting the balance of that power. And it's about being flexible and responsive, and it's about ensuring where possible. We never sort of say that we've done a representative engagement unless you've really kind of dug into the stats, but even with that, there's different ways to cut and splice the data. So I'd never really say that I've got a representative group on my advisory board, because often that lends itself to things like tokenism, like I just need one person of this description, one person of this description, one person of this description, and therefore I've covered off on equity and I've got a representative group. I think there's more to us as humans and we're multidimensional, and there's more to us than some of our demographic characteristics. So I kind of avoid that, but really thinking about those things and intersectionality in that way. So what is co-design? As I said before, it's collaborative design. Some key ingredients for me, and this is where I think you'll start to see that maybe we don't do co-design as much as we think we do. For example, I am been doing this work now for over 10 years, and I think I've done true co-design twice, maybe 3 times, and that's literally been the focus of my job. It's really about you've got to actually genuinely share the power. So you're basically having a group of people that have as much say and decision-making power and authority as you do, which a lot of organizations aren't comfortable with. You have to make it clear to people what their sphere of influence is. And you have to really be comfortable with not knowing. So in what I mean by this is that both your destination, what you're going to produce, what you're going to achieve together, and your journey, how you're going to get there, they actually have to be up for grabs, because you're actually working with a group of people where you're saying to them, we are going to co-design this together. Your expertise is as important as mine. Therefore, I can't come in with a set of preconceived ideas about what we need to produce. So it really can be quite challenging, because it also, I guess, in a funding context, that makes that really tricky, because there's not a lot of funding bodies out there that are going to fund you to do a project where you say, I don't know how long it's going to go for. I don't know how many people we're going to reach. I don't actually know what we're going to produce or what we're going to achieve. And I don't know how much it's going to cost. So true purist co-design really is a little bit incompatible with that sort of a funding model. But it's about, if you are doing true co-design, it's about really sitting comfortably with that weird feeling of not knowing where you're going. Yeah, the journey and the destination have to be up for grabs, and creativity must be unleashed. So for me, this is where we don't actually do a lot of co-design when we say we're doing it. If you're going to say, I've done a co-design workshop, or you've taken a co-design approach, there has to be an element of design in there. You have to unleash creativity. And part of the reason for that is when we're doing plasticine models or playing with pipe cleaners or painting or doing a river of life or whatever, you're actually unlocking different parts of our brain and coming at problems and coming at issues and coming at topics from a different angle. And that's where co-design, that's what co-design tries to leverage. So it's not just butcher's paper and sticky notes, and we've done a workshop because we consulted with people and therefore we're calling it co-design. It actually is about, there's got to be a design element in there. It's got to be a creative process. But who would fund this? As I said before. There's lots of different models for co-design, and I just probably will say really quickly, because I know I'm running out of time, these are sort of the rough steps that we see across all the different models of co-design. So first, it's about engaging, understanding. So we do something like a day in the life, or you might develop some personas or vignettes to understand what it's like, creating something together, testing it, and then implementing. What is not co-design? Like I said before, it's not just butcher's paper and sticky notes. That has a place. Like I said before, we don't always have to be doing co-design. That has a place, but you just can't call it co-design then. And that there is a clickable resource. So I've got that little pointer there. So all these things, yeah, not necessarily co-design. I'm going to, these are all in my slide pack, so I'm not going to go through them now just in the interest of time. But there's also here on this quiz, if you're now going, oh, am I been doing co-design then? Or is that, do I know co-design as well as I thought I did? There's a really good, on that link there's a really good quiz you can do. And it actually steps you through some of this stuff about, am I actually sharing power? Do we have creativity and design built in? If not, you're doing engagement, you're doing a collaborative work, but we're just not calling it co-design, and it still has a place. And so when you're not doing co-design, here are the sort of, this is my Bible, the IAP2 spectrum of engagement. For those who haven't used it before, many of you will have, I imagine. I guess the idea about this is that the more we go up the line of engaging with people, the more power we share, the more impact we possibly will have. And so I won't dig into that too much more, but the goals are there, and as also, I guess, an example, an illustration of what that might look like. So along the bottom in the promise column. And really, it's about how much power you give over, and how much loop closing you do, and how much the people's contributions and ideas are actually what you end up implementing. And there's some examples here with some clicks on them, clickable links that you're welcome to look at. And as I said before, it is very okay to run your own race. I do this a lot. Sometimes it's the path of least resistance, and you get a very similar outcome that you may have gotten if you had done a co-design process for 6 months, because there was delays and everyone was fighting about different ideas. Okay, I'll stop. Sorry, I went over a little bit longer.
Awesome. Thanks, Michelle. I found it really interesting that you mentioned not always word co-design that we think about guarantee success. It needs to be meaningful.
Cool. You go on mute. I can't hear you. Sorry, I didn't hear that. Can you repeat that? Sorry.
You can't hear me?
I can hear you now. You cut out partway through. I'm not sure if I'm someone else. Sorry.
No, I was just saying that it was very interesting to me that you were saying that co-design is not, it's just beyond the boards, and it needs to be meaningful, not just we think that we are co-designing, but not right meaningfully engaging with our stakeholders. Really interesting.
Yeah, yeah, and I see that quite a lot, particularly in the world that I work in at the moment. People say co-design 25 times a day, and I just don't think that's what we're doing, and I think that's fine. I just think that we have to be real about it, because what we run the risk of, the people that are actually doing co-design, they're not saying they're necessarily doing it, they're just getting on with it. And so and then on the flip side of that, the people that aren't doing co-design are saying, we're doing co-design, we're doing co-design. And so funding bodies and decision makers think that's what good looks like, and that's what co-design looks like. And so then they just continue to fund that stuff. So people who aren't doing co-design are getting funded to do co-design. And the people that really need the money, who are doing true co-design, the lengthy, bulky, meaty, creative stuff, are not getting it, because it's so hard to articulate what it is and what you're going to do and what you're going to achieve and how many people you're going to involve in it. So it's really tricky. I think we really need to be really deliberate and mindful about when and how we use that word.
So true. Great. So now we are running out of time. We might move on to our next speaker, who is Mrs. Renea Camilleri. Renea is a registered nurse and a registered midwife with APRA. She has postgraduate qualifications in midwifery and women's health medicine. She is the Women's Health Week and Community Engagement Manager at Gene Health for Women's Health and a casual academic teacher at Peking University Faculty of Health. She has been working in the non-for-profit sector for the last 5 years with experience in public health and education, project management, indigenous health, stakeholder and community engagement, policy, gender equity, research, and health promotion. Welcome, Renea. Over to you.
Thank you so much for that introduction. I'm just going to share my screen. Okay. Hopefully you can all hear me okay. Beautiful. Welcome. My presentation today is on managing PCOS in Indigenous communities, a community-led approach. So just a bit of an overview on some of the things that I'll cover today about the project, engagement and consultation, looking at the outcomes of the project, some of the challenges we experienced during the project, because of course this was a 3-year project, which a lot of it was done during COVID. And we will also touch on the evaluation, some key recommendations and some takeaways as well. If you have any questions, just feel free to pop them in the chat. So this wonderful project that we did was actually in partnership with the Illawarra Women's Health Service on behalf of the Central Australian Aboriginal Congress. And this project leveraged off existing relationships between Gene Hales and Congress in the Northern Territory to improve the lives of Aboriginal women in their service delivery area, and looked at bringing community together on expertise in community understanding and reach, and the education and knowledge and exchange and clinical expertise that we brought from our end. I'd like to actually acknowledge the health professionals and women of Bandyopadhyay in Alice Springs and the surrounding communities who actually contributed to this project and the resource development, and also acknowledge that this project was funded by the Commonwealth Government. I was not a one-woman show. I'd like to also acknowledge the work of my colleague Rose Duplay, who was also the project officer on this project as well. So as outlined, this initiative encompassed community and health professional awareness and education on PCOS, with the community and in response to their needs. So a little bit about the background of the project. So Aboriginal women and girls from rural remote areas are identified in the National Women's Health Strategy as priority populations. And we know that polycystic ovarian syndrome disproportionately affects Aboriginal women and has a significant impact on their reproductive health. And the latest evidence shows that lifestyle modification is an effective tool in the management of the condition and its symptoms, particularly through hormonal regulation and a reduction in their risk factors. So the overall purpose was to co-design culturally appropriate and relevant resources to the overrepresentation of Aboriginal women with PCOS. And there were to be a few different phases within this project, which involved consultation, development, and also delivery of some tailored resources on PCOS for both health professionals who work with Aboriginal women in Alice Springs and also the surrounding communities, but also the Aboriginal women and girls in Alice Springs and the surrounding communities as well. So these are just some of the objectives we had as part of the project. So we wanted to increase awareness around the condition, its presentation and impacts among the community and also health professionals, create accessible, relevant and culturally responsive community resources, and also look at increasing health professional ability to diagnose and manage the condition in primary care. So consultations. So we asked women and health professionals about resources and the education they wanted to help them learn about the condition. So we did this in 3 phases. So phase 1, we did health professional consultations and we surveyed 33 health professionals working with Aboriginal women in Alice Springs and the communities around. Respondents from this cohort included GPs, we had midwives and nurses who worked in women's health, chronic disease and also remote nursing, health service managers, a dietitian and an Aboriginal health practitioner. The survey aimed to identify, the health professionals' confidence in diagnosing and managing PCOS, and also looking at the barriers to the diagnosis and management of the condition. There were questions also asked around possible facilitators to the diagnosis and management of PCOS as well. And these were done as one-to-one Zoom and phone consultations. Phase 2 included community consultations, which I'll go through shortly, and then also phase 3, which was a small cohort of Aboriginal health workers and practitioners. So as I mentioned, we did the survey for health professional consultations, and some of the key findings around the resources or the challenges in diagnosis and management of PCOS were asked, taking into consideration any barriers and challenges identified in a previous question. What would assist health professionals in the diagnosis and management of PCOS in Aboriginal women? So we had about 80% say PCOS resources for women that are culturally appropriate, such as brochures, postcards, videos, and just under 80% mentioned a toolkit for health professionals to help them educate Aboriginal women around PCOS. Now, our community consultations were conducted in partnership with our project partner, Alukra Women's Health Service, and they took the form of semi-structured interviews with Aboriginal women about their health information needs relating to PCOS. So they took place at the Alukra Health Service in the presence of a senior Aboriginal staff member. And we asked them questions about their current knowledge of the condition, their needs and preferences for receiving health information, areas of PCOS they want more information on, and also some general questions around healthy eating and physical activity. We also worked with a cultural advisor to demonstrate that this was also culturally safe. And the women that participated were also reimbursed for their time. And phase 3 was Aboriginal health workers and practitioner consultation. So we provided some education sessions around PCOS and the project at some of the clinics in Alice Springs. So this included the Alukra Clinic and also Northside clinics. And we showed them some examples of some other resources that have been developed for First Nation groups and also for multicultural groups. So we showed examples of this brochure on pelvic floor or leaking urine after having a baby from the Continence Foundation. And then we also showed them a toolkit, an educational toolkit that we had developed in partnership with the Centre for Culture, Ethnicity and Health around health checks. So we provided the community examples of these resources. So some of the outcomes of the project, so after the consultations, we identified the following resource priorities. So for health professionals, they wanted a webinar on diagnosis and management of PCOS, particularly in the rural health context, and also an educational toolkit to help health professionals deliver education about periods and PCOS. And for the community, they'd mentioned that they would like things like booklets on periods and PCOS and also animations. So involved in the resource development, we had the project team here at Jean Hales. We had the steering group members, which were a mix of people from Congress, Jean Hales, and also the Department of Health up in Northern Territory. We also had clinicians from Jean Hales and the Alukra Health Service. We had a lead Aboriginal cultural advisor and an illustrator, animator and artists were also engaged. So this was the suite of resources that we actually developed. So we developed 2 toolkits with an accompanying brochure. We developed some some posters for raising awareness and accessing the information that could be put up in clinics. We developed 2 animations, again, one around PCOS and one around periods. And then we also did a webinar for health professionals around diagnosis and management of PCOS. Now, the artwork, we engaged a local artist by the name of Amanda Gorey, who's an Aranda artist who grew up in remote communities around Alice Springs. And we also engaged Coolamong Creative, and they are an Aboriginal owned and run creative service also based in Alice Springs. The design brief was guided by the project team here at Jean Hales, but also the manager of Alukra and the female lead Aboriginal cultural advisor from Congress. So the evaluation, so we had an independent researcher from Charles Darwin University evaluate the project between August 2022 and January 2023. And the purpose of the evaluation was to find out whether the project was developed and implemented as planned and whether the co-design approach resulted in resources that are acceptable and useful for Aboriginal women in Central Australia and the health professionals who work with them. And the evaluation was based on the Lewicha framework and included an online survey of people involved in the project, an online survey for healthcare professionals, interviews with Aboriginal women in Alice Springs, and then analysis of the project documents. The evaluation found that overall the quality, benefit and the effectiveness of co-design approach taken for the project were of a high standard, and Aboriginal women were generally positive about the resources. They thought the information was simple and easy to understand and that the illustrations captured the diversity of Aboriginal women. So these were just some of the key recommendations that came. So this is just over 2 slides and conscious of time, so I don't want to go through all of them. But one of the things that, obviously with COVID and all of that was ensuring that project planning and design provide sufficient timeframes, and particularly working with an organisation that was quite struck for time because they are seeing patients all the time. It did get difficult at times, but I think overall we worked pretty well to get this project completed. And this was another, some of the other key recommendations, prioritising translation of resources into key local languages. So far, we've only translated it into Central Aranda, just based on budget constraints, but also time to complete the project. But we are looking at ways to ensure that we fulfil some of these recommendations going forward with other First Nation projects that we will be involved in. Some other considerations for co-design are, culturally safe training for non-Indigenous staff, which is something that me and my colleague undertook. The development of really good, strong partnerships is really important, especially in co-design projects like this. Seeking representation of the Aboriginal and Torres Strait Islander community, and engage an evaluator who's done work with Indigenous communities or is a First Nation-led research group. These are just some of the challenges. Obviously, the COVID-19 pandemic really took a lot of time for us to actually get out and do consultations with community, because we know that they prefer face-to-face consultation. Steering group meetings also at times were challenging because of the flexibility, but also the availability of staff to attend meetings. And also the commencement of evaluation started a lot later than we had anticipated. So these are just some of the resources. So our Gene House resources, or the suite that I mentioned during the presentation, and also the link to the Luicha evaluation framework that was used. So thank you so much for listening. I hope this was insightful. Yeah, that's it from me.
Thanks so much, Renee. Great body of work. I might be a biased person to comment on your talk, because I personally work in the area of PCOS, but in general population. And I do understand how challenging would be for women not getting a diagnosis for a long period of time, even in the general population. And it's also very, very challenging for health professionals to give a diagnosis given the heterogeneous, complex features of the condition. Well done, great body of work, would be very helpful to underrepresented population. Unfortunately, we don't have time now to go through your questions. Don't worry, we will go through your question at the end in our Q&A sessions. Now it's the time to move on to our next speaker, who is Mr. Andrew Perusco. Andrew is a Sarah and Wilson PhD scholar placed with the National Centre for Aboriginal and Torres Strait Islander Wellbeing Research, Australian National University, affiliated with the NHMRC Centre for Research Excellence in Achieving the Tobacco Endgame. His PhD research explores why Australia has failed to adopt tobacco endgame policies. He is a tobacco control policy and program specialist with 25 years experience in the public sector. His achievements include contributions to significant tobacco control policies and program implementation. Welcome, Andrew. Over to you.
Thank you, Mahnaz. I'll just share my screen. Hopefully everybody can see that now. Is that okay? Yeah. Before I start, I'd just like to acknowledge the traditional custodians of the land in which we work, live and play, and pay my respects to the elders past, present and future. And I'd in particular like to acknowledge the Ngunnawal and Ngambri peoples on whose land I present from today in Canberra. Before I start, I just have to mention the disclaimer. I did this work that I'm presenting today when I was working for Sydney Southwest Area Health Service, but currently, or for the last 15, or close to 15 years, I've been working with the Australian Government Department of Health and Ageing. And I just need to say that the presentation really focuses on my research findings and perspectives, and doesn't necessarily represent the position of the Department of Health, the Sir Roland Wilson Foundation, who is funding my scholarship, or the AMU. I'd also like to thank the other authors who I worked with on this project called it's actually called the Mafish Sigara Menhe Khosara campaign. That's the Arabic pronunciation. The translation is every cigarette is there is no cigarette without loss. And we developed that through this campaign, but I'll get onto that in a second. And I'd just like to acknowledge the other authors and also some of the people that contributed to the project and organisations, such as the Australian Lebanese Association of New South Wales. So here it is, the main hero image that we developed through this health promotion campaign. And I should just put in context also, this was done quite some time ago, and so we probably weren't using the same sort of terminology that I'm hearing from Mitchell and Renee when we talk about co-design and things, but I think the basic principles were there. I'm just going to give a quick background about why we targeted or worked with the Arabic speaking community in Sydney, and that is because culturally and linguistically diverse populations continue to have very high rates of smoking. And at that time, they were a priority for the Department of Health in New South Wales, but they remain, culturally and linguistically diverse populations remain a priority in the National Tobacco Strategy, which was released in May 2023. So at the time, Arabic speakers were the largest population of non-English speaking smokers, or people who smoke residing in New South Wales. I think currently now it's moved on to Mandarin and Cantonese speakers, but that's just the context in which we were working then. And when we did our baseline survey, we found that the prevalence in Arabic-speaking males was high at about 35.4% of, and most of them middle-aged Arabic-speaking males were smoking. So at the time, there was some evidence to say that there were various population health interventions that would work to reduce smoking, such as but not limited to mass media campaigns and smoke-free zones, for example. There was also just a few evaluations that conducted with culturally and linguistically diverse populations. I'll just call them cold populations from now on. That there was not really enough evidence to suggest what would work in campaign strategies for these populations. But getting on to the project development for this project in particular, the planning for the project commenced in December 2002, and you can see, give context about how old I am now, but this is work we started then, and I think it went through to about 2007. And the project team used a number of processes to inform the selection and development of strategies for the project, and to clarify the main target group and theme and message development. So the key processes were an evidence review, just looking at systematic reviews. We held 2 consultation forums with Arabic workers. We conducted analysis of data from the baseline telephone survey to help us look at knowledge and beliefs. But we also did lots of focus groups and then also focus testing of resources. And I just want to point out these wonderful Arabic health workers that we worked with on this campaign. These were multicultural health workers from the community health stream of the service, and they were instrumental in the project, and they were on the project management committee. And so they were highly involved in all aspects of the project development and implementation. They were really, really important in terms of linking the project with the community and Arabic community organisations and other relevant services. They had really strong cultural expertise and provided advice on cultural safety, particularly important in this community in particular that had large diversity with a number of communities coming from very different countries in the Middle East, for example, but also North Africa. And they were instrumental in conducting consultations in Arabic. They were also working with translators to ensure survey tools and other project resources were culturally and linguistically appropriate. And one interesting anecdote here is because we knew that, for example, that the Lebanese population was the biggest population of Arabic speakers in the area that we were working in. But we had the Arabic health workers saying to us that we should actually have all of our campaign materials, audio and anything visual actually in the Egyptian dialect. And this surprised us, but it was because a lot of the movies that were made for Arabic speakers were made in Egypt. So across all of the population, Arabic speaking populations, the dialect was easily understood. And that's just one example about if we didn't engage appropriately with these workers in the community, would have had no idea about these sort of things. So I think the underlying approaches that we used for developing this campaign were informed by an older document. And noting I'm going back 15, 20 years, what was influencing us at the time, but there was the New South Wales Health Capacity Building Framework, which emphasised things such as leadership, funding, valuing partnerships, and training with key organisations to make sure that we're doing things in a sort of co-designed way. Although, as I said earlier, we weren't using those terms at the time. The leadership and funding commitment from the Area Health Service was really crucial, as there were substantial resources provided over a number of years, and that was particularly important in terms of co-design. So the leadership in cross-service partnerships was really important because the Arabic health workers were multicultural health workers who were a different part of the service, and we needed to ensure that they engaged across the whole period, which ended up being from about 2002 through to 2008. And glad to say that when I was as part of the health promotion service there, that the perspective was that the project couldn't really proceed without the cultural expertise and experience of the Arabic health workers who were part of our project, and also the broader community, bringing them along with what we're hoping to achieve. Importantly, as managers of the project from the health promotion service, is that we never made unilateral decisions. And one example I'll give from more of a, the expertise in tobacco control side is that we knew that mass media campaigns were going to be the most important approach. But we had the Arabic health workers and some of the community members thinking that nicotine replacement therapies would actually, if we subsidise those, that would probably be the best thing. But we knew from all of the evidence that if we invested in those strategies, we would have very, very, if any at all, influence on the population levels of smoking, or the smoking prevalence. So we spent weeks taking the Arabic health workers through some of that. And I think we demonstrated that going through that process, we could actually get an outcome also that the health promotion service felt really strongly about. Now here's the hero image on a bus, and I didn't talk to it, but you saw on the presentation slide that we had a number of different strategies, and I must say that we really saturated this audience with these products. Some of the results. So great result in terms of the multivariate analysis showed that the baseline smoking prevalence, we did a pre and post survey of over 1,000 people in each survey, and the baseline found that 26% of people were smoking amongst Arabic speakers in the area, and then at the post it came down to about 21%, and that was statistically significant. But the worrying thing that we've got here is that we can see that the smoking prevalence, which is great, it almost halved amongst the highest socioeconomic status group. But when you look at the lowest and moderate, the decline wasn't as great, and it wasn't the decline wasn't strong enough to actually find a statistically significant finding there. There's some of the key barriers and challenges. I'd say implementing a truly co-designed project takes a long time commitment to get all of the aspects of the project right. And one example is that we would translate into Arabic and then have it back translated to make sure that we were getting the right messages across. And we had to also invest in lots of focus groups to make sure that the messaging was actually conducive to the way that some of the Arabic-speaking communities thought about the world. And if you go back to our hero image, you see that the family is at the center of that whole hero image, and that you see that the father is potentially falling off the picture here. And that's because we wanted to target Arabic-speaking males because the smoking prevalence was so high, and they weren't quitting in middle age, which is in the riskiest time to smoke, really. So I might just go back there. I might have missed a few, sorry. So time required to negotiate goals and approaches to the intervention was important. But overall, the inequitable benefit from the intervention suggests that structural changes are required. So that means, focusing on the social determinants is really going to help in the future for populations with high smoking prevalence. But in terms of when we look at what we're doing overall in public health, we have to move for tobacco control. We have to move away from what is called the consumer sovereignty paradigm, which dominates tobacco control approaches, and really makes it an anomaly in drug control. So, for example, the drug that causes the most health and social costs in society is tobacco. It's not any of the illicit drugs. Illicit drugs are about 14%, tobacco causes about 56%, and alcohol about 26%. So all of the illicit drugs cause the main problems in our society. But when we're looking at tobacco control, we can see here that we're using a very sort of light touch approach to it, even though it's the worst drug on the market. So the conclusions, I'd like to point out that despite the limitations mentioned, health promotion interventions and investments for priority populations can have a marked influence on health risk factors. And most importantly, this was achieved through working closely with the priority population to ensure appropriateness and safety. But as I'm demonstrating, we do need to think more broadly also about the type of interventions that we're using. I'll just finish by briefly mentioning my PhD focus. If this catches your fancy, you can just do a quick search for my name, Andrew Perusco, and proposal review, sorry. And if you look at that, you'll get more of a précis about what I'm doing. But I'm looking at why we haven't adopted what's called endgame strategies in Australia. And you'll see in New Zealand that it's been a very progressive approach that they're implementing in New Zealand to get tobacco off the market, to make it less addictive, not to take it off the market, but to reduce the supply of tobacco in New Zealand, but also to ban the sale to people born after, I think it was the year 2009. So I just want to point out that I'm using sort of co-design approaches in my PhD, and I'll point out some of these articles which are really important. The Snarch article is important in terms of understanding why how power has affected Indigenous health research. So it provides lots of examples about that. So it's really good for people that haven't explored in that field. The Harfield one is about quality tools for Indigenous research with Aboriginal and Torres Strait Islanders, but also the Huria one goes through all of the principles that align with co-design as well. So it's the principles of governance, prioritisation, relationships, methodologies, participation, capacity analysis, and dissemination. And I've just finished by saying my PhD seeks to use the principles of co-design and engage Aboriginal and Torres Strait Islander policy stakeholders in approaches that address structural issues that drive tobacco use. So thanks for your time. I hope it didn't go too long.
Fantastic presentation, Andrew. Thank you so much. Being myself from a cult background, I really like the bit that you highlighted. Working with cult population is not just about language. Cultures across countries may also be different. That was really interesting. And now we've got only 4 minutes to go through a few questions. I might start with the last one I can see in the chat box. And unfortunately, Renee had to leave earlier, but I can see that Mitchell and Renee have been actively responding to questions. But I start asking you, Andrew, because you didn't have the chance to read the chat box. How did you control researcher bias creeping in during the data interpretation and analysis phase?
That's a good question. I mean, we had people involved in our research design who were not part of the intervention. And so what we did is also is that we took a step back when we developed our baseline survey, for example. And what we did there is we went and had a look at all of the previous research, and then we finalised it with the Arabic workers as well. So we didn't. It would have been better, I think, if we had a totally independent evaluation. But I think to make it actually realistic and useful for our project, we had to have some level of involvement in that. The other thing that we did do is that we didn't get involved in the actual surveying. And I didn't go through all of this, but at the start I said that McNair acknowledged McNair Ingenuity Research, and they provided all of the surveys pre and post. I don't think there was that much distance either in terms of the focus groups and things in our campaign. So I think it is a slight weakness, to tell you the truth. But I think we had quite a broad group on the project committee, so that we had community members there as well, having an input into the way that we design things.
Great, thank you. And Mitchell, we had a question to all the speakers, which was, could you elaborate on the challenges that the person asked they, I think she or him and stakeholders faced, and how they overcame them to strengthen the collaboration?
Yeah, so I mean, I didn't talk about a specific project whilst I have a few in mind, so I might pick one now. So one of my projects I did was similar to Andrew's. It was, and also to Renee's. It was working with multicultural communities, in particular this time Afghan and Tamil speaking communities in southeast of Melbourne. And we had an advisory group for both of those projects. The advisory group was made up of community leaders from those communities, about 7 or 8 from each of those communities. And anyway, one of the topics that we were getting a real strong sense from the community, and our volunteers who were also from those bilingual bicultural workers from those communities were saying to us was an issue was mental health, family violence, and LGBTIQA+. And we took that to the advisory groups, and they sort of said to us, happy for you to talk about mental health, be sensitive about it, here are some things to avoid. Happy for you to talk about family violence, be sensitive about it, here are some things to avoid. Don't want you talking about LGBTIQA+. We don't think that, we don't support that. And so we as an organization who were Rainbow accredited and were very gender and sexuality inclusive, we found that tricky. So basically it was just a negotiation. We just talked to them through where this has come from, why we feel the need to sort of support that, and that actually, as their roles don't need to be seen as endorsing anything. We can kind of move that into the project in different ways, and volunteers sort of who are happy to sort of take those messages on and develop some health literacy campaigns and projects about it. We'll go with that, and we'll do what we can. We don't need to necessarily make it a really big feature of the project, if that makes you feel more comfortable. And so once they understood the purpose and the intent, and they understand where the insights had come from, they sort of came on board. So with anything like that, it's always just about the negotiation and the way that you frame it. And I think most of the people that we have as part of these projects tend to be relatively sensible and have and use common sense, and can actually, if they're taken on the journey and they understand the process, can tend to be quite rational and reasonable about that sort of thing. And so as long as they're explained and you're good at communicating it and also writing it down, like putting it in writing, then it tends to be okay to work through.
Thank you very much. Mitchell, we might stop here. Thanks for everyone for joining. Please don't forget to come and join us for the networking session, which will be started in about 10 minutes at 11:10, and then we will be having workshop 3 on working with public health policy and law regulation at 12. All have a lovely day ahead. Take care. See you. Bye-bye.